programs on global sustainability and resilience here at the Wilson Center that includes our maternal health initiative. And I'm really pleased that we're able to have that initiative. We do it in conjunction and with support from the Maternal Health Task Force at Harvard University and with UNFPA. And we've been doing that for a few years now and have been quite successful in that endeavor. As I think about our topic this afternoon, I almost have a checklist. Humanitarian, check. Urban settings, check. Meeting maternal and newborn health needs, check. Displaced persons, check. This seems to me to be such a critical checklist for us now on a series of issues that are really important. You know, we have been looking at questions on displacement, on refugees for a while now. It is something to which we have been giving increasing attention of late, but not always are we able to look at the health dimensions, particularly from a maternal and newborn health perspective, and be able to put that in a humanitarian context, and particularly in urban settings, is really important for us. The other checklist, as I think of our event today, is Wilson Center, check, of course. Save the Children, check. Maternal Health Task Force, check. Key partnerships. This is really so critical to what we do. I think many of you are familiar with us here at the Wilson Center. We serve as a living memorial to President Wilson, just one of two living memorials shared to our presidents. And part of what we focus on is bringing communities together to explore, to examine, to really key critical issues, to get outside of the Beltway. This is not an inside Washington, D.C. conversation. We're very much concerned about getting the right people at the table to have this conversation. And we know that many of our colleagues are also tuning in online and engage us in that conversation. So our dialogue today is webcast live. And when we produce a summary of today's discussion, we know we have many people who comment on it, who go back to it and refer to it. So our conversation today will have a long shelf life. And that is really important for us. Our focus at the Wilson Center is on independent research, open dialogue, and practical solutions. We don't really want to have a talk, we want to have real talk. And real talk means looking honestly at the challenges and the opportunities, but really moving forward to what we can practically be doing about these set of issues. And I'm really just pleased that one of our real talk partners is once again Save the Children. This is part of a series that we're doing with our colleagues at Save the Children. And just earlier this year, in January, we co-sponsored an event with our partners at Save the Children that focused on urban disadvantage, maternal and newborn inequalities among the urban poor. So this is the second in our series of this important collaboration with Save the Children. So welcome. It's wonderful to have you here. And it's particularly wonderful for me to welcome Mary Nell. We've enjoyed the support and collaboration with the Maternal Health Task Force at Harvard for some time now. As you can see from the bio sketch, Mary Nell is the executive director of the task force, and she has been there since 2011. Prior to working at Harvard, she worked for a number of different development donors, non-profit organizations, and community-based agencies in international public health, a field that she's been in for a good tenure. And I know as Mary Well and our colleagues were preparing for this session, they had just had a very good debrief, and Mary Well said, gosh, I feel as if we almost just had the panel. So this is wonderful to have you here. Welcome to you all, and I'll hand it over to you to kick us off. So thank you and welcome.
Thank you, Roger Mark. I too am excited about more real talk, having felt like we just had a lot of real talk getting ready for the panel. We had a fascinating discussion, and I'm excited to share some of that with you through 4 extraordinary panelists. I also want to thank Roger Mark and our colleagues at the Wilson Center and Save the Children for what has been an incredible collaboration. So it's fun for me to get to be up here knowing how rich our collaboration and cooperation has been. As we think about the situation with refugees, and as we sort of narrow the lens on maternal newborn health in urban humanitarian settings, I was struck by something I recently read where someone was interviewing Paul Spiegel at Johns Hopkins, and he said there are currently 65 million people forcibly displaced, and that 1 in 113 individuals will be driven from their homes. Those are staggering numbers, and that made me think more about what we're going to talk about today and putting it in the context of this sort of enormous number of people. In addition, I've learned, thanks to my colleague Lonnie, that more than 60% of the world's refugees and 80% of internally displaced persons are currently living in urban areas. And for many people, in contrast to living in a camp setting, urban centers offer both greater economic opportunities, access to services, in some cases a degree of anonymity or distance from the label of being a refugee or an internally displaced person. But they also pose incredible challenges. Local systems are often already strained by growing populations. They may not be equipped at all to handle an influx of more people. And they may also be especially challenged by the fact that refugees and IDPs so often settle in especially poor and marginalized parts of cities, including slums and informal settlements, where residents typically already have such limited access to services and perhaps no access to high-quality services. So when we think about that in terms of women who are seeking prenatal, delivery, or postpartum care, the situation may be especially complex. And today, as I mentioned, we're going to focus our lens on refugees or displaced people who, for now, are living in urban areas. We're going to look especially closely at the situation of women and newborns and the kind of health care they have access to, as well as the larger ecosystem in which they're seeking and receiving care. In order to understand the situation better, we have 4 really fascinating panelists. I get to say that because I've gotten to spend an hour with them now, and I know you're not going to be disappointed. I'm going to ask each of them to speak for about 10 minutes, and then I'll pose a few questions. I promise not too many questions. And we'll then have a broader conversation with all of you and with anyone participating via live stream. I want to start by introducing Samer Saliba, the Urban Technical Specialist at the International Rescue Committee. In this role, Sam's currently gathering evidence and advising on how to improve urban humanitarian response in both policy and practice. Previously, Sam worked for 7 years as an urban planner, bolstering the resilience of New York City in the context of the northeastern U.S. And through his involvement in innovative programs such as Rebuild by Design and the New York Rising Community Reconstruction Program, the National Disaster Resilience Competition, and others, he's worked directly with at-risk communities, regional municipal government agencies, and numerous other stakeholders in developing integrated resilience strategies that go beyond the basics of community planning. At the IRC, Sam works with country offices to support their urban response portfolios and the cities they benefit, helping them to design programs, pursue partnerships, and build resilience. He's currently focused on urban refugee response in the Middle East, Europe, and East Africa. So a big welcome to you, Sam. Thanks for coming.
Thank you for having me.
To Sam's left is Dr. Stephanie Caden. She is director of Harvard's Humanitarian Studies Initiative and also director of the International Emergency Medicine Fellowship in the Department of Emergency Medicine at Brigham and Women's Hospital up in Boston. As director of the Humanitarian Studies Initiative at the Harvard Humanitarian Initiative, those of us at Harvard say Harvard a lot, Stephanie trains graduate level students as well as professionals working in the field of global humanitarian health. She also serves on the editorial board for the American Medical Association's Journal of Disaster Medicine and Public Health Preparedness. She's vast experience in the field, having helped to develop emergency medical care in Bhutan, Fiji, Nepal, Japan, Germany, Serbia, El Salvador, Ethiopia, Israel, and the Palestinian territories. She provided disaster relief to the survivors of the 2005 Kashmir earthquake in Pakistan, helped rebuild health systems for Burundian refugees in Tanzania, and led a team to improve rural public health in Uganda. Stephanie also helped to establish a field hospital for survivors of the earthquake in Haiti, and I know she's just gotten back from Haiti, so we may get into some discussion about what's happening there now. With teaching experience on the subject of health and human rights in more than a dozen countries, Stephanie's well published, including a recent article on the effects of conflict on health in Liberia. So welcome, Stephanie. To Stephanie's left is Sarah Ashraf, who is a reproductive health advisor in emergency health and nutrition at Save the Children. And she has been working in the humanitarian field for the last 15 years. Prior to working with Save the Children, Sarah worked with UNFPA and WHO. In 2004, she joined Save in Darfur, Sudan. Since then, she's been deployed and worked on various emergencies, including the typhoon in the Philippines in 2009, the earthquake and then the cholera outbreak in Haiti, the Libya emergency, and others. She's currently supporting both the Yemen and Pakistani country offices in both emergency medicine and reproductive health, and also works with Save the Children's programs in Egypt. And she's going to share a little bit more about what she's doing there with us today. Thank you for sharing those experiences, Sarah. We're glad you're here. And to Sarah's left is Alicia Wilson, who is the executive director of La Clínica del Pueblo here in Washington, D.C. Alicia's been working in the field of social services since graduating from college. She first served as a case manager, working with the homeless and working poor in and around Washington, D.C., and then shifted to work with HIV-positive Latinos at La Clínica del Pueblo. After playing an increasing role in the leadership of La Clínica, she was selected to become their executive director in 2009. She also currently serves as the vice president and of the board of directors of the DC Primary Care Association, and she's treasurer of the board of the Institute for Public Health Innovation. Alicia serves on the DC Department of Health in the Bureau of Cancer and Chronic Disease Community Leadership Team, and is a member of the National Steering Committee on Promotores de Salud, convened by the Federal Office of Minority Health. And finally, Alicia has played an active role in local healthcare advocacy through her frequent testimony in front of the DC City Council, as well as her work in coalitions across the region. As a result, she was named a Disruptive Woman to Watch, which is a title I really like, by Disruptive Women in Healthcare. Thank you for joining us, Alicia. It's clear that each of these people I get to sit with up here has very relevant experience to bring to the discussion. And I'd like to start by asking you, Sam, if you would help us to understand more about what the IRC is doing in this space and what public service delivery means in the context of urban displacement. So over to you, Sam.
Great, thank you, Mary Nell. It's a pleasure to be here. And as my presentation gets set up, I think one word you didn't hear in Mary Nell's introduction of my background is the word health. And that's because my health expertise is entirely focused on my first job working in my father's OBGYN office at the age of 15. And that's when I quickly decided that a career in health was not for me. But nonetheless, I do know the terminology from that experience. But in my role now, I am focused on figuring out how we as an organization can better achieve outcomes in urban areas, better health outcomes being one of them, And I'm going to talk a little bit today about our work in that field. Thank you. So just while this gets set up, the first slide you'll see is this one. There we go. It's you know, as a humanitarian organization, working in cities is just by nature a part of our long-term vision, and figuring out how to better work in cities is a part of that as well. That's because urban refugees are increasingly dominating the humanitarian landscape. So this is some stats that Mary Nell, actually you touched on, the fact that 66% of the world is becoming urban by the year 2050. And within that trend of urbanization, forced displacement is occurring as sort of a microcosm of that bigger trend. And now you see 60% of refugees and over 50% of IDPs are not in camps and in rural areas, but actually in towns and cities. And when you look at Syrian refugees, that number actually jumps up to 90%. So what does that mean for the humanitarian community? And I actually want to put that into specific context. Consider the city of Dar es Salaam, where we do some work. There are the estimates vary among the number of urban refugees living in Dar es Salaam, but there's anywhere from 5,000 to 10,000 refugees living in the city and coming into the city. And this is also a city that's growing exponentially with economic migrants, others from Tanzania, and economic migrants from around the region as well. And so what that means for us as humanitarians is that we need to understand how to operate within a larger dynamic that's happening, as well as a more complicated and constantly changing space that is the city. And the other thing that we need to deal with is two competing experiences. So I don't know if people can read these two quotes behind me, but the first is from a refugee living in Dar es Salaam. And he says that I went to my ward office with a series of grievances concerning exploitative practices against me. The ward officer promised to connect me with legal services for refugees, but never followed up. So that's the specific legal discrimination that refugees can often face living in a city. Couple that with the general marginalized experience of people living in often secluded, off-the-grid neighborhoods, which lacks the access to public services that the CBD, the Central Business District, might have. And you have this quote: "Children are not receiving the education they should be getting. The level of education in itself is low. In one class, there are about 150 students. It's hard for a teacher to pay attention to all of those students." So this is an example of education as a public service, but it equally applies to health as well. So when you look at the refugee experience in cities, you have both what I say sort of the two strikes against them. Because they often come to marginalized areas, they then share in the marginalization of host communities in the lack of services that they can access, as well as in the case specifically of Tanzania, which has an encampment policy. Many of the refugees who live in Dar es Salaam are not legally allowed to be there, are there with irregular migration status, and therefore are legally discriminated against or against the public services that are offered to populations of the city, as well as social discrimination. So people not afraid of sending their kids to school for fear of being bullied, people themselves not going to work for fear of being exploited against in the workplace. And so there's this real disconnect between the services that are being offered on the supply side and the demand side of the users of those services not being able to access them. And that's particularly true of displaced populations in urban areas. So my job today is to sort of frame this, and I think I can best frame this by this concept, the definition of the idea of the right to the city. And for the IRC, we define the right to the city as an urban dweller's ability to safely and fairly access public and social services, opportunities for self-sustainability, education, employment, healthcare, and safe and welcoming environments in which to reside. So this is really the challenge that we as humanitarians face, is establishing the right to the city for displaced who choose to come to the city because of the opportunities that they present. And what they often find is that their expectations are not met when they come to a city because of the various reasons that I mentioned before. So how do we build the right to the city for urban displaced? How do we get better at meeting their expectations when they come to the city and expect to access services and opportunities that they might not have in towns, in rural areas or in camps? You'll see that public services is sort of the theme of today is health as a public service. And I have a definition for that as well. I promise this is the most text-heavy slides that you'll see. But I think it's important to understand, and IRC has a paper coming out on this, around how humanitarians can support public service delivery in urban humanitarian settings. And to do that, first you have to understand what a public service is and what a public service system is. And so we define them as those services that mainly include and recognize as rights-based services that a government is entrusted to deliver to its population. And healthcare is a key example of that. And if you think about the system of public service delivery, you can think of it as the supply side, public service providers, the demand side, the users of public services, and then the infrastructure, the roadways and different ways of getting services to and from. So this is, I'm sure, I know many development actors that deal with public services on a regular basis, but it's a bit new for the humanitarian community. And so what my own research has is it highlights these 4 key ways of better engaging with public service systems in order to make them more inclusive and better adapted to the needs of displaced and marginalized residents. The first is understanding the complexity of a city, and I can't emphasize this enough. I mean, I often say that I in 7 years as an urban planner, I never once got the question, how do you define urban? But I get it on a daily basis within the International Rescue Committee. And it's a challenge of just the terminology of working within a new community and a new professional network. There's just a level of understanding that we need to reach when it comes to the number and diversity of opportunities, systems, stakeholders, infrastructure networks, everything, housing, built environment that exists within a city that doesn't exist in other places. And that's the kind of understanding that we need to get at. And it requires collaboration across different expertise to really achieve that. Speaking of collaboration, coordination and collaboration when you're responding to a city is critical. That's often because you're coming into a city and there are pre-existing services and pre-existing service providers that are there that won't be there if you're establishing a camp, that we need to get better at working with. And then engaging in organizational capacity strengthening of municipalities and service delivery. And lastly, advocating for PSD providers to be more inclusive of users. So if you want to simplify this, which I would encourage you to do, it's sort of these three rules of thumb. Collaboration, system strengthening and organizational development, and advocacy. And the reason that collaboration and advocacy are highlighted behind me is because that's where the IRC has a lot of strong examples. We do have strong examples of system strengthening and organizational development with working with health ministries in certain countries. But what I want to highlight now is one specific example that I just came back from is with the city of Amman. The Greater Amman municipality was writing their resilience strategy, which addressed everything that the city was facing in terms of shocks and stresses. And this was an initiative with 100 Resilient Cities, which is an initiative of the Rockefeller Foundation. And they asked the IRC to come and help write their city resilience strategy to be more inclusive of displaced and marginalized populations. And so it was our responsibility to go in and speak with public service providers to better understand what services they were offering, how to make them more inclusive of displaced and marginalized populations, and how in this strategy we can outline clear and concrete ways of working with the municipality, with other NGO actors, and with national ministries to enact those actions that are more inclusive and more considerate of the needs of displaced populations. And I'm very proud to say that the first word in Amman's resilience strategy is welcoming. And I think that says a lot for the direction and willingness of the municipality to engage in this way. And it was really in large part because of us engaging in that dialogue and seeing where there was common ground. I just want to end with one concrete example from that action. And so this is one action that's in that strategy. So they had pioneer daycare centers in Greater Amman municipality buildings. And then we recommended that they add, and that's highlighted in orange, that they work with civil society organizations to identify and support women-run businesses in marginalized neighborhoods and invite them to utilize daycare centers while providing safe transportation services for them and for their children. And this is just one of 16 actions within the resilience strategy that considers the needs of displaced and marginalized populations. If you want to read it yourself, you're more than welcome. It's at resilientamman.jo. It's resilientamman.jo. And you can clearly see, I think, a concrete example of collaboration between a municipal service provider and many service providers and an international non-governmental organization. And we're looking forward to working with them and implementing these actions here on out. And what we really want to do, and this is what it comes down to for me, humanitarian actors are trying to deal with a crisis in a city, and local authorities are trying to manage a city in crisis. And so it requires collaboration, it requires advocacy, and honestly, this is the part that happens the least is simply saying hello, believe it or not. We as humanitarians just sort of land in a city and don't often take the time to say hello to the public service providers and the existing systems and stakeholders that are there. And if you just take that step, I often say you'll be amazed at how willing and how many opportunities there are to collaborate there on out. So looking forward to the discussion. We have a fantastic panel who we'll talk about health, I promise. But that's it for me, so thank you.
Thank you, Sam. Thank you for not talking about health.
Yeah.
That was fascinating for me to think, as a health person, to think about the broader context, to think about some supply and demand side issues, and also to realize, although I've been to Dar es Salaam many times, I have not looked into their policies, and to think about what it means for refugees in an urban environment there to be legally discriminated against, in addition to what social discrimination refugees so typically face all over. And I love the example of Amman as well. So I want to say to Stephanie, welcome and hello.
Thank you very much. And with your permission, Mary Nell, I think I'll move to the podium because I feel like I'm blocking everyone's vision of my own slides.
Absolutely.
Okay, super. Thank you very much. It's a pleasure to be here with all of you today, both those of you in the room and those of you online. I hope you'll submit lots of questions. What I wanted to talk about today is health. So Sam gave us the perfect intro to this, because really when you put health in an urban setting, everything changes. And that is nowhere more true than in the humanitarian community. So we're going to look at the challenges in health in urban refugee crises. So it would seem to a lot of people that being in an urban setting should bring a lot of advantages to refugees as opposed to being in a rural setting. Now, if you look at some of the data from the World Health Organization that is shown here, it shows you that that infant mortality actually decreases the more urban a setting you find yourself in, which seems like that should be good news and a great urban advantage. The problem is it depends which neighborhood in the urban setting that you're in. Because in urban slums, where many of the world's displaced people and refugees gather, along with the local severely poor population, the opposite is true. Infant mortality actually is increasing the more urban slum you become. And this is the problem, I think, for a lot of the refugees who have been displaced into urban settings. Now, they face a number of challenges. Number one, there is a lack of access to medical care for many of these refugees, either because they can't afford even the nominal fees, or sometimes more importantly, it's that they are afraid to seek out care or simply don't know where to go. In many contexts, if you're a refugee and you seek out care, it requires registering with the local authority, to gain an ID card that gives you access and entitlement to those services. And many refugees are simply afraid that if they register for these services, that they will be tossed out of the country, even if it's not true. So there's a lack of access to care. The other thing that is difficult is there are inadequate toilet and sanitation facilities in many of the places in the urban areas where they settle. And they are often choosing the most cost-effective place in the city, and that can be slums. So this is a situation that sets them up for even more disease and ill health. Same thing goes for water supply. Water supply in some of the slum areas and a lot of the urban areas is absolutely insufficient, and there isn't enough clean water for the people who are settling there. And finally, there's just plain overcrowding in a lot of these areas. When you have an overcrowded situation, the communicable diseases, measles and such like, will transmit very quickly from person to person. And something that on a normal day in a more spread out living situation could be manageable suddenly becomes an outbreak and a crisis every single time. So these are the problems that cities present for refugees. Now, refugees in cities find themselves coming with another set of issues that makes it very difficult for the local public health system to keep up with them. The refugees are very mobile. They may move from day to day, seeking out better resources, a different job, or what have you. Most of them often come in very poor. If you had to suddenly flee from your home 5 minutes from now because an army was encroaching, what would you think to pick up? Especially if you're a woman. Do you go and try to find the cash stashed under your bed, or do you pick up the toddler and the baby? Right? Most people pick up what they can and go. And so the journey itself can be very costly, and by the time they arrive and settle in a city, they just don't have the resources. Another thing that they lack, that even many of the urban poor who are not displaced have, is a support system. So many of us know that in networks of poor people around the world, if one person gets ill or is having a bad time, they can draw on the support system, their family, their friends, maybe borrow money around, and many refugees lack this sort of embedded social support system. So even though they're living in an overcrowded place, they're quite isolated, and that makes them more vulnerable. And finally, there are often language problems. So refugees that are coming from another place may not speak the local language, and since we are dependent on a lot of the local health services to provide them what they need for health care, especially higher level health care that pregnant women need and newborns need, there is a huge barrier to care just from language access. Now, that may seem strange to some of you who maybe work in a health setting in the United States where there is a requirement for hospitals to provide translators and interpreters. That's not the case in most countries in the world, and it's not even the case in most European countries. So even the refugees who find themselves displaced into some of the European countries find that the language really keeps them from accessing care. So what is the result of all of this? Well, we're going to look at some figures from a wonderful report called Hidden Cities by the WHO and UN Habitat. And I encourage you to have a look at these because it really spells out what the problems are for women and children. Here is a graph of under 5 mortality rates in urban areas. And you can see that all of these problems are going to hit the urban poor the most. And over time, we have not made a lot of progress in under 5 mortality rates. So if you look on this slide, here's the change in under 5 mortality rates in the urban areas. And it's gotten a little better around the world, but it's not dropped to nearly the same levels that we've been able to see in other geographic locations. Now let's look at chronic malnutrition. This is low height for age or stunting. This is not the severe acute malnutrition that we are commonly used to seeing in humanitarian emergencies in Ethiopia or Darfur or these places where people suddenly lose weight. This is the result of a lifetime of insufficient nutrition. So in this photo, you can see a group of children who are 9 years old, and they should be as tall as that line on the wall. because the line marks the average 9-year-old's height in that country. But these kids are stunted and have grown up without proper nutrition and therefore are smaller. So that's the marker for us. If you look at this rate of under 5 chronic malnutrition in urban areas, you see that it is extremely high, especially among the poorest children. And the problem here is there's been almost no headway made in chronic malnutrition for that poorest segment. The Americas have done fairly well, but in many places in the world we see that this is a very stubborn problem. Finally, turning to mothers now, skilled birth attendants in urban areas. Again, the urban poor especially, who encompass much of our refugee population, find themselves without access to skilled birth attendants, whether that's a midwife or a doctor. And so their deliveries are much more dangerous than the average. About 5 to 15% of all deliveries will run into a complication that requires some sort of surgical intervention. 5 to 15%. So this is not a small number of mothers who need these skilled attendants, and they're not getting them. And here again, we see that really very little headway is being made in the world. So as the refugee crisis increases, as the world urbanizes, and as more and more of the world's refugees are found in urban areas, what can we do? So here are a few strategies that we work with in urban humanitarian response to try to leap over some of these boundaries. First, the main way of working for humanitarians in the urban setting is to enhance local infrastructure for public health and health systems. And that's very different from what we are accustomed to doing in the old-fashioned rural humanitarian responses, where you go out into a desert area or a rural area and you pop up a field hospital if you need one, or you start a food distribution program if you need one. In the urban context, that response really doesn't work very well. And so it's a lot about working with the local infrastructure, partnering, and trying to use local markets and using cash instead. So the next thing we have to do is work with the local partners, which is extremely complex. There are government partners, local aid agencies. There are a lot of people around that you suddenly have to meet, get to know, and learn to work with to make urban humanitarian response work. So it falls to us to really advocate for access to the local health system and engage with the refugees themselves in outreach programs to educate them about the availability of these services, so that they feel safe accessing them and they just know where they are. Finally, it falls to the humanitarian community also to work on cash distributions. A lot of times within the local or urban environment, there are things there that would help people, food, water, healthcare, but they can't afford them. So giving cash as a means of aid is one way to help them access the services. And the last thing we can do as humanitarian urban responders is do our best to monitor indicators and the status of these refugee populations. They can be enormously difficult to find in an urban area, especially because they're moving around so much. But if no one takes the time to look after them, monitor their situation, and advocate for them to the government and to the local aid agencies, it becomes much harder for them to get aid. So the world for urban humanitarian response is a new and very interesting one for us in the humanitarian response field, and I look forward to the rest of the discussion.
Thank you, Stephanie, for sharing these insights. I think it's fascinating to think back to that early slide you shared, which has WHO's infant mortality in cities, and then realizing we can't assume it's going down if people make it to urban areas, that in fact the opposite may be true in really vulnerable neighborhoods in urban areas. I also was struck by your point about language as a barrier to care, because I think those of us in this country are used to having the opportunity to have the benefit of interpreting and translating services, and to think about what that means for so many of the kinds of services that people need. I'm going to turn to you, Sarah. I know one of the points Stephanie made was on enhancing local systems, and you've done a lot of work on that with Save the Children. And I wondered if you would share with us some of your insights from working in and around Cairo.
Yes, thank you. Yes, so while the presentation gets set up, yes, so I'm going to talk about our program in Egypt, which started around 2013 and was a program that was established for refugees, Syrian refugees, and also refugees who were Sudanese, who were Somali, Eritrean, and recently also many from West Africa, so a number of different nationalities. A little bit on the numbers in Egypt. So there is some confusion with this. There are different numbers that are quoted, but I think the most reliable ones with UNHCR are that currently the country hosts refugees all in urban settings around Cairo as the capital city, and then around Alexandria, which is a little bit of a distance from Cairo, but all of them in the outskirts and in the ones that we supported, the program we set up was around Giza. Giza is a governorate on the outskirts of Cairo. And there are about 120,000 Syrians who have registered with UNHCR, but then the government believes there's also additional 120,000 who have not registered. So again, there is that mix of refugees in Egypt, some registered and many who are not. These are only Syrians, but then we have the mix of other nationalities as well. And there are others who are asylum seekers among the Sudanese and the Eritreans and Ethiopians, and also those who are not exactly termed as refugees. And then almost approximately looking at these numbers, we have 63,000 or 60,000 women of reproductive age, and of which almost 5,000 would be pregnant. And out of those 5,000, 1,000 plus would be those women, estimating, according to what Dr. Stephanie, you said, would need health care that is beyond just primary health care in this setting. So the program we established was around 2013. It was with PRM funding, with the help of PRM funding. And at that time, a number of assessments that we did showed that the refugees did not really access public health facilities that often. They only accessed them if they had to. So those who were registered, which were a limited number, had a refugee ID card, and using that ID card, they were able to go to certain health facilities that were predefined by UNHCR and were managed. Their services in those health facilities were managed by organizations, different organizations. Now, those health facilities were not necessarily in those areas where the refugees were living. So they had to travel out or take transportation in order to reach them, and then they could only avail them if they had the card, if they had a registration card. Of course, that we can understand issues related to that were, of course, finances and getting to there, and even understanding, even information, understanding on how they could reach those health facilities was an issue. At that time, particularly the Minister of Health of Egypt declared that the refugees in Egypt would be treated as Egyptians when it came to healthcare. And I still remember a colleague from EMRO, from WHO, told me that when he heard that, he thought, well, it's a nice way of welcoming refugees, but then the question is, what do Egyptians have in terms of healthcare in Egypt? So although that did open up the venue where refugees could access public health facilities if they wanted to, it also meant that then they had to have extra pockets of money in order to pay for laboratory diagnostics, for medications, for prescriptions that they were given, and much more. And the situation also got much more difficult when we went from the primary level to the secondary level. So at the secondary level, of course, diagnostics and prescriptions were much more expensive, and that those could not be afforded by the refugees. Many of those assessments also showed that to a large extent there was also a lack of understanding of the refugees in Cairo on part of on the public health system that was there. So there were reports that with focus group discussions that we did, that we understood that refugees did complain and say, well, we waited a long time in the waiting area, we were not called in for services, we were given a prescription that was really expensive, we didn't know where to go, or others maybe had access to medications that could be subsidized, we didn't. So this was some of the things that came out of the various assessments that we did. Again, there was a lot of issues related directly to reproductive health services, maternal and newborn health services. And again, we know, I think it goes without saying that no matter the situation, refugee or not refugee, women continue to be pregnant, continue to give birth, newborns continue to have their health needs. And I think within all this, that was a huge, huge gap in secondary hospitals and tertiary hospitals for the refugees. In areas where they resided in the outskirts of Cairo, the public health facilities were public health facilities that the quality of services were not that good. They were not well equipped. So initially when we started with a health facility assessment, and our health facility assessment showed us that lots of the supplies and equipment that were necessary to provide even basic maternal newborn care, reproductive health care were not there at those primary health care facilities. So the program decided, based on all our assessments and our findings, to implement a program where we would try to link the refugees into the public health system. And we started doing that by establishing community health centers. So the community centers that were established for refugees were in two areas at that time, in Ardelewa and another area called 6th of October. And these community centers were not just for health. They were community centers where refugees could come and access a variety of services. So there was informal education for children, for adolescents. There were child-friendly spaces to look at protection issues related to children and adolescents. And then there was a lot of health awareness and health education that went on in these community centers. The community centers were there also to host social events, to bring refugee communities together, to do a lot of conflict resolution, because the refugees were of so many different nationalities. There were many times issues between people of different nationalities, to look at those, to try to manage those. Those community centers were also the hub from where linkages could be formed. So linkages between refugees who needed access to a certain kind of healthcare, needed to go to a hospital for a cesarean section, or a newborn that needed to be admitted into a neonatal care unit. So those were the community centers were those linkages where refugees could be guided to the appropriate health facilities. Alongside that, of course, what we did is we mapped some health facilities that we could select and prepare in order to be there available to provide those services to the refugees. So that included primary health care facilities, but also included one hospital that through our assessments we understood refugees access quite often. So we managed to build their capacity, provide supplies, provide equipment, and make sure that they were able to receive the refugees. One other important and very interesting thing that happened was that during all trainings that were provided to service providers, there was a lot of training done on understanding emergency health, humanitarian situations, refugee health. Who are refugees? Where do they come from? What are their needs? So a lot of that was built into all of the trainings that we did. We also expanded the program to include a reproductive health program, which focused mainly on family planning, post-abortion care, but a lot also on emergency obstetric care referrals. So this program directly supported women, refugee women, who came to the community centers and who were out in the communities and help them to get services that they were not able to have. So with this program, we were able to develop family health cards for refugees at the primary healthcare facilities. So a first-time visit by a refugee family, they would open a family healthcare card. They could then revisit, bring other family members, and come back to the same health center again. But then they could also avail secondary health care through the community centers with support where they needed support in terms of finances, diagnostics, and everything else. Now that, in order to do that, the program also made linkages with all other programs that were there, like the IOM, like UNHCR, many other organizations that were then helping to make services available. I just want to share this one graph that kind of shows how implementing a reproductive health program in those settings through the public health system by training on family planning showed a very remarkable kind of result for us since 2016. We've had 5,500 acceptors of family planning. 60% of them have chosen long-acting reversible methods. So again, it's just a small example showing how investing into the public health facilities, training the healthcare providers, bringing in the right supplies, and then also educating the district health offices and the system there about refugees and about their needs kind of brought services or made accessibility possible for refugees. Very quickly, just to summarize, I think some of the strengths were definitely the community centers. It was a huge strength. That was the hub and the point where everything could be interconnected, the stakeholders, the refugees, and everyone. And then all the work that the community workers did and the social workers did. And supporting, of course, I already said, the primary healthcare system. Challenges still remain, and the biggest challenge is the cost of secondary healthcare still remains as refugees increase. It is a huge challenge for Save the Children, for UNHCR, for others on ground to make sure that every secondary healthcare facility that the refugees access, they're able to provide them with the right service, and then the refugees are able to afford it. And then maintain a support to the health system for that, because there is high turnover of staff. Egypt is going through its own political issues, which translate into the health system as well. So trying to manage those. And then managing the expectations of the different nationalities that the program deals with. So not only language, but also cultural barriers, also making sure that people's norms and customs are respected, and that through that they are able to receive what they need. And I just highlighted the health information system because to me this was very interesting. We incorporated the program through the public health system, but how then do we actually capture the extra information that we need regarding refugees through the health information system that the Ministry of Health runs? I think that it still remains a challenge. We are trying, but I think it's one of our still our learning areas that we have. Thank you.
Thank you, Sarah. I was struck by your point about the registration card being something that's pivotal, and I hope we can talk a little bit more about that, whether people choose to identify as refugees or carefully choose not to identify as refugees, and just the role of communication and cards maybe in general, family health cards you mentioned. And I think also touching on a point that each of you has discussed so far, where refugees and internally displaced people get their needs met vis-a-vis existing systems in urban centers. It seems like there's a lot of work to do in that area. And Alicia from La Clínica del Pueblo will help us to think a little bit more about that and some other issues that resonate with those living right here in Washington, D.C.
Great. Hi, everybody. I'm Alicia Wilson, and I'm very proud to be the executive director of a community health center based here in Washington, D.C., as well as in Prince George's County in the suburbs, serving primarily low-income Latinos. And we've been around since 1983. We were created in response to the first wave of migration from Salvadorans fleeing the war in the early 80s, and have always been a combination of Salvadoran migrants and North American response, sort of combining forces to create a community-based health center. When we first started discussing this panel, the word refugee rarely shows up in our work because I would view a lot of the people that we serve as refugees without recognition. We serve folks who have fled war and conflict and natural disaster, but never been afforded the recognition as refugees, which then leaves them out of the formal support system for refugees. But for those of you who are local and have been around the DC metro area for a while, the last 35, 40 years have shown a dramatic boom in the Central American population in the DC metro area. Now, the 14% of the DC metro area is Latino. That's, I think, like a 500% increase. It's the fastest growing population in the area, and what distinguishes the local population compared to other Latino sort of high population Latino areas is the presence of Central Americans. When you lack official refugee status, you're excluded from many of the traditional safety net benefits here in the United States, such as Medicaid, food stamps, TANF, refugee cash assistance, case management supports, and beyond. For the folks that we see at La Clínica, we have sort of viewed our patients as having come in waves, more or less on a decade basis, and ironically, almost always a couple years right after census data is complete. So, 1982. 1991, and those things where it's often difficult for the government infrastructure to catch up with the boom in the population because waves are coming after the official count. What we also find is that the booms have happened regionally, but also in distinct geographic areas. Again, for those of you who've been in the DC metro area for a while, Mount Pleasant and Adams Morgan were the boom areas, and now it's Prince George's County and some areas in Fairfax County where booms come, but often the social services and support infrastructure lags because the support infrastructure is often built after a boom happens, and then people migrate to new areas in search of better economic opportunity or reduced cost of living. So our latest boom that we're experiencing is the boom in unaccompanied minors. This is just a photo from, or a map from a few years ago describing where folks are coming from, but this is absolutely the wave that we are grappling with right now, which bears a lot of the same characteristics of previous waves, but is impacted by all of the previous waves as well. And when we talk about maternal and child health, we see the impacts of these waves of migration as really dramatically affecting the family structure. The patterns of migration that we've seen are families that are separated, and then when they are fit back together, they often have extremely complicated relations. The trauma that families have experienced separate and together has a compounding effect, and the trauma of the migration journey as another complicating factor. An example that I will give is one of our patients who was 16 when she came to this country. Her father had come ahead of her by about 10 years, so she was about 6 when her father moved to the US. She was under pretty significant threat from gangs in her home country, and so her father decided to send for her, paid a coyote to bring her. So she fled the fear and strife of the gangs in her hometown, was harassed by a coyote on the way, was kidnapped from that coyote by a gang in Mexico, Her father had to pay ransom to the gang, who then dropped her off at a detention center. She was then released from the detention center to her family here in Maryland to meet stepmother and 2 sisters that she'd never met before. And managing the complexities of the family dynamic, the needs of this girl and the needs of all of her siblings and the whole family as it reintegrates, thinking about a 16-year-old girl now integrating into a high school, integrating into situations where she needs access to birth control, she needs access to the emotional support, and the overall health support is compounded by the complexities of the trauma that she, her father, her sisters, and beyond have experienced, each in their separate way. One of the characteristics of the patients that we're seeing is something that I'm calling sort of transnational families and transnational communities. This recognition that community is not necessarily based on geography. We've had some lovely discussions about the role of Skype in maintaining communities and maintaining families, but also in navigation of the safety net. As we have at La Clínica many patients who have heard about our services in El Salvador, in Honduras. We have patients who know about us before they arrive because they have family and they have trusted confidants from their hometown who are now located in DC and receiving our services. And so the navigation of the social service safety net and the support network is not necessarily just about being published in a local directory that someone can find the information. There are many other ways that people can navigate to get the information. It also, I think, plays on the reliance on informal networks. A lot of the patients that we see have significant distrust of formal institutions, government institutions, and beyond, and put a lot more weight on somebody who can vouch for this is a good clinic where they treat you nicely, or this is a safe place where they're not going to question your immigration status when they provide you services. If you look at La Clínica del Pueblo's female patients, I think one thing I would just highlight is we have a disproportionate percentage of our prenatal patients who are under age 19. This is, when we talk about maternal and child health, we have to be talking about adolescent health and the complexities of young pregnancies and, again, these very, very complex families as you integrate the migration experience, the home country experience, and the new sort of new settling experience. And when I was preparing this presentation, I thought what I should really just say is it's complicated. I think when we are working with adolescents in particular, we're dealing with right now a lot of adolescents who have had persistent stress and fear and trauma, constant anxiety, which can really affect their brain development, affect how they interact with the world. They're also bringing with them their cultural norms of gender roles, of access or lack of access to family planning in many aspects that govern how one works on managing her own fertility and her own self-determination in terms of family planning. We're also working a lot in how to mitigate the impact of sexual and gender-based violence, both in the migration journey as well as immigration status being used as a weapon in gender-based violence and control. We have many, many female patients who are in abusive relationships and feel they're unable to leave because their partner controls their immigration status, and not having the safety of being able to navigate to a separate place. Or their coyote is also the father of their child, is also the person to whom they owe money for the journey, and it's complicated. So, we'll see if I can navigate through. I wanted to give a couple very quick examples of some programmatic responses that we have in the face of these issues. One is a program that we have that's called Mi Refugio, or My Refuge. It's a, thank you. It's a culturally sensitive youth development model that really is focused on resiliency building and therapy, community building, legal services navigation, and supporting families in this reunification effort. We're based in a school-based setting, and it's been extremely successful in actually improving graduation rates, reducing dropout rates, and helping support young mothers who either came with their young children or came here and then became young mothers as they're still trying to navigate through high school. Another programmatic response that we have is a program called Entre Amigas, or Between Friends, that is a gender-based health program that in particular uses promotoras de salud, or health promoters, to lead our efforts, help navigate as peer supporters the needs of the women served, and really support women in their sort of journey toward self-determination. Also dealing with the family reunification from the mother's side. Often we'll have mothers here who are sending for their kids when their kids come. One of our staff says, it's like you give birth again. It hurts that much. And having your kids come after a long separation is an extremely challenging experience as well, with lots of complications. Finally, I'll just close up and say, as we have developed all of our programming, we've drawn on the lessons from our founding, which is to truly be a community-based organization, we need to be run by the people we serve. We need to constantly be refreshing our services and approach with the input and guidance of the people we serve, if we have any hopes of meeting our mark. Building in structural feedback loops, building in structural ways to make sure that we're meeting our clients' needs is the only way that we can survive and continue to have good outcomes, as well as sharing our lessons learned with other providers so that we can build a safety net that's beyond just our four walls toward a much more enhanced, welcoming community for newly arrived folks. And with that, I'll stop there.
Thank you, Alicia. That was fascinating, and I'm also struck by some of the overlap in some of the points made with the other speakers. It sounds like sexual and gender-based violence is not a theme only you are working on, and it also sounds like there are big issues around data and monitoring and trying to build or create the smartest programs possible to serve the communities you're working with, and having those communities, in fact, design and serve on programs seems like a really critical component. It also sounds like technology is a really important facet of keeping families together or keeping communities together, even if they're separated by vast geographies. And occasionally, although I can be very down on technology as the mother of teenagers, it seems like it's serving a really important role. So I wanted to open up these issues to our panelists and ask, maybe for starters, given that Alicia spoke about the role of sexual and gender-based violence and trying to help girls and women find their agency in a very complicated social dynamic universe, if others have dealt with that issue or seeing that in the populations you're working with, if you have any insights on programming around that particular issue.
Please.
Yeah. So it was the SGBV program was a huge part of our program in Egypt. I didn't go into details because of timing. But when we started the program in Egypt with assessments, it was clear that that was an issue that refugees were dealing with and needed a response. So we started by trying to equip the facilities, training the providers on the health side and then looking where linkages could be made for psychosocial care for the survivors of SGBV. And that initiative kind of built up really fast in Egypt, and all the other organizations pitched in, and then eventually the Ministry of Health was able to develop their own protocol for SGBV, which actually has a chapter on refugees. And that protocol was then translated into an action plan for training the healthcare providers all over Egypt, not just where refugees were resident. There was a lot of work that was also done through, again, the community centers, through the workers, through the social workers. Many of those cases would come to the community center. That's how we would get to know about them. So there was a lot of psychosocial care and services provided also at the community center once the healthcare was taken care of. However, having said that, the percentage of survivors that actually showed up at the health facilities were very, very few. Still remain to be really, really small numbers. And I think that we did an assessment specifically for SGBV for this program, and it showed that because of the very complex environment where we had the public health system, we had so many organizations involved, many nationalities as refugees, the trust building that is required for survivors to actually trust the health facility, and then others to come forward and to talk about what happened to them and then to avail services, that trust building is the challenge with all these many actors and many players in the mix. So maybe I'm hoping that with experiences like this, maybe we can find a way where SGBV can be programmed in urban settings in a way that that trust building can be allowed, or there could be other mechanisms to provide services, maybe not through the public health facilities, maybe through focal persons or providers who are trained but are not necessarily sitting at a health facility. So, yeah.
It's an interesting thought. There may be a different kind of community component or community point person who could be especially valuable in a situation like you're describing. I don't know, Stephanie or Sam, if you've come across this issue in the work you're doing, if there are any comments or questions you'd like to add?
Yeah, I can touch on not in my work, but in my research. So there's a report that the IRC has called Violence in the City, and it's a systematic review of the drivers of urban violence. And what that found is actually there's not a ton of evidence on what to do about urban violence, but there is a ton of evidence on the fact that violence exists at many different levels for refugees living in the city, and GBV especially. So for those of you familiar with the socioeconomic model, there's instances of GBV at the structural, at the community level, as Sarah, as you talked about, but also at the familial and the individual level. And at the community level, you have things like lack of GBV services from police, from judicial, and from health actors, just the understanding which some people talked about. But at the familial level, you have issues like male control of household decision-making and wealth, limited mobility of women and girls, which I think is a uniquely urban issue as well, and then intimate partner violence, child marriage, which is particularly prevalent now in Lebanon and Jordan, which you see a higher rise of child marriage between Syrians and Lebanese, or between Syrians and Jordanians. And that's sort of an interesting dynamic from when you talk about urban, because you're talking about refugee households living side by side with host community. And I think, Stephanie, you talked about cash. And I think one of the most interesting things from that report was that at the top of all of that is actually economic strain is the driver of many different kinds of violence. And so if you're looking to address the root causes of violence, of course, there's very specific things that you need to do, but also just economic empowerment, establishing livelihoods, cash distribution can get at some of those core issues as well.
Thanks. Stephanie?
And I'll just add to what Sam said. All of that is correct, of course. But you know that the sexual and gender-based violence is certainly nothing new to refugee communities. This is something we've seen for a very long time. You mentioned I'd worked in Liberia, and part of what I did there was to engage in a study of the sexual violence prevalence among the entire nation's adult population post the conflict in Liberia. And what we found was, when we talked to the women, we found that 1 in 3 of them had been a victim of sexual violence during the conflicts, which is a pretty standard number if you look around the world. But the more surprising finding was that 17% of the adult male population of the entire country had also been victims of sexual violence during the conflict, which was a much more surprising number. And I think that if you look at not only that kind of data, but also what we see in post-disaster context all over the world, both in the United States and elsewhere, we do see that sexual and gender-based violence does tend to rise. Intimate partner violence rises after disasters, and part of it is the stress of the disaster, part of it is economic stress. So these are things that also happen in the urban area, but are just a little more difficult to get at, because in those areas, as was mentioned by Sarah, the trust levels and people feeling safe seeking out care is a much bigger issue.
Thank you. You mentioned when we were speaking before the panel that you'd been in Haiti last week. Right. And as I think about sexual and gender-based violence, there's obviously a really important component to that complicated issue that is dealing with survivors of that experience, whether female or male. And there's also, I think, an important twist on that in service provision to try to prevent or be prepared for the possibility of sexual and gender-based violence. And I'm wondering if any of the programs either you're working with in Haiti, and I know that's a local group, or programs that any of you are working with are also thinking about it from the perspective of preparedness or prevention. Can I just put you on the spot, Stephanie?
Sure. I think everyone tries to look at it from preparedness and prevention. It is a fairly standard part of humanitarian response or response in refugee situations to include a gender-based violence program within the health program. I think that for today's more urbanized crises, the real problem is how can you implement that, and how can you reach out to the refugee community? And so when we build these programs, we do try to write those things in, but I don't know that anyone has found a very easy, quick, very reliable way to make sure people feel safe. And that I think we're still looking for the magic bullet.
Yeah, fair enough.
I also feel that lots of the prevention, protection mechanisms that we at least started seeing way back 2004 in the SPHERE guidelines and other guidelines were very much based on a camp setting. But now I think with the urban settings, the situation is completely different. And so many of those very basic prevention mechanisms or programming mechanisms that we put in, interventions that we put in, probably don't all apply to our urban settings. So I think this is something we clearly saw when implementing or when trying to educate refugees who came to the community centers on what could be some of the prevention mechanisms. We had to kind of brainstorm and discover some prevention mechanisms from them, rather than us presenting ideas like we are so clear on when we're in a camp setting.
Yeah, good point. And I think the importance, as we're thinking about maternal newborn health, what it means, given what we know about how common sexual and gender-based violence is for pregnant women, what that means then for the kinds of health care those women can access and the kinds of care their newborns will get.
Certainly in the primary care setting, there are some good tools, like screening tools and trainings for healthcare providers to detect trafficking, to be able to screen for violence in the home and beyond. I think one of the major challenges has been to connect the dots. If the screening comes up positive, what then? And I think that making sure that health facilities are well integrated with other supportive networks is really critical, and accessible to the people that you're serving. I think at La Clinica, we have a number of gender-based violence programs, but we're unusual as a health center to have those in-house. And for our patients who may be limited English proficient to then try and access a shelter or access legal services, the navigation support is really a necessary part of it to be successful. I think for when we think about from a prevention standpoint as well as a support standpoint for survivors is really looking at the use of lay health providers and promotores or community health workers as trusted community members who know what's happening before a health provider would know, who would know the network and be able to help people navigate. And so our Entre Amigas program trains survivors as peer accompaniers who say, here's how I applied for a U visa, here's how I got a restraining order against my abusive partner. I will go to court with you because it's really scary. I did it before. And having the folks from within the community trained to support others then creates an extraordinary social network of folks who then tell someone who tells somebody, oh, you should talk to this lady, she knows everything about it. And that is that informal network then can integrate with the formal network of healthcare provision and beyond. And it has been a very successful program for us.
Great. I also wanted to ask one more question, and then I promise to quit monopolizing the conversation. Stephanie, you brought up data monitoring and collection and tracking, and I feel from the perspective of those of us who advocate for maternal newborn health, there's always the question of numbers. How many women and newborns are affected by whatever? And so part of that data I think of as being a really important advocacy tool, and I also think it's obviously very important in terms of service delivery design and program design. And I wanted to ask our panelists what attempts they might have made or what sort of creative tools they might be aware of to try to help track important data. What are those indicators? How are you tracking them? What are you doing with that information if you are able to collect it?
So there are a number of newer technologies that have emerged to gather data about refugee situations around the world. In urban settings, a lot of the health data needs to be collected either at health clinics and health posts or on a household level survey type structure. And that's very difficult because it requires finding a very mobile population in an urban setting. There are other ways of tracking things like refugee population movements. There are some mobile services that are able to track anonymous data, but linked to people's mobile phones, so they can track the movement of the mobile phone, and you have a good sense of where the mass of the population is moving on to. Those don't always help us collect health data, but it can help you know where to look for the refugee populations. And some are using mobile-based communication not only to track health data, but also to help improve healthcare for refugee populations as well. So through text messaging systems, they can remind people of appointments or check in, how's the baby doing today, that kind of thing. Mm-hmm. And that can be a more efficient way of providing services than to require that the refugee come to the clinic every day or what have you. Mm-hmm. I don't know if you use some of those services, but they're becoming more common.
Does anyone else want to comment on data and tracking and monitoring? Or are you ready to move on?
I think we're
okay, Stephanie, you did a great job. You answered for everyone. I want to turn the discussion now to those of you in the audience in this room and also in the audience via internet, and learn what your questions are. And if you'd like to direct a question to a particular panelist, feel free, or if you want to address a question to the entire panel, that's also fine.
Presumably you can also tweet your questions even if you're in the room as well, for those of you who are shy.
Go ahead, there's one in the back. I don't know, Francesca, do we need questions to go through the mic so they're...
Yeah, and state name and affiliation to the webcast.
Okay, terrific.
Hi, I'm Lucy Mize, Asia Bureau Health Team for USAID.
a number of you mentioned cash transfers as a part of your approach, but in the settings which are so insecure, cash can make people very vulnerable. So I'm wondering if any of you have been exploring with like electronic through a smartphone or any kind of biometric cards so that people can indeed access the services that are there, but not make themselves more vulnerable through that program.
Interesting question. I don't know who.
I can
Jump
pick
in.
that up. So you're absolutely right. I think in the early days of using cash transfers, it was cash in an envelope type transfers, which indeed would make any of us vulnerable, even here on the streets of Washington D.C. I think walking around with a wad of cash. And now those days are largely gone, and wherever possible, the cash transfers are much more commonly done by debit cards, or the biometric linked methods are most common in areas like in many parts of India where biometric data like fingerprints are already used to identify people. It's a little strange for some people to start with that. But the other thing that's commonly used is text message, mobile phone cash transfers like M-Pesa. So those systems are much more secure because the card or the mobile phone is not so obviously just freshly recharged with cash, and yet it's still very easy for people to use, especially in the urban setting where many people will have access to ATMs relatively nearby. That can be a really good method, and it's much more commonly used. The only caveat, of course, with using cash is you have to ensure that local markets are operational. So if you want to help people by giving them cash, you can do so, but only if there is healthcare available to buy with the cash, or if there is building products or proper food available in sufficient quantity in the marketplace. And so a lot of organizations who do, for example, food security or food distribution, even more and more they're in the business of evaluating and helping to rebuild market structures so that they can then very easily hand over cash rather than having to give out items to refugees. And I would argue that the same thing goes for healthcare. It's great to give cash so that people can go to the local clinic, but if the local clinic is already seeing 250% more people than it usually has been built to see, it's not really helpful to give cash in a situation like that.
Thank you. Did you want to say?
Yeah, well, I might just add. So I think part of addressing the needs of urban refugees is allowing them to, or giving them the knowledge to better navigate their environments. And I think one concrete example for cash is that it's not an example of us giving cash, but it's an example of we were seeing many refugees crossing from Turkey into Lesbos and actually carrying their cash with them, which was a tremendous risk. Many people ended up losing their cash, not realizing that once they got to Mytilene, which is actually a somewhat urban area, it's a small city, there were money transfer stations there that they could safely access. And so what we did as IRC, there's two things. Is one, there's actually an online platform called refugee.info. You can access it yourselves if you want. And what that does is actually provide information to refugees based on their place of the place that they're currently in, so that they're better aware of what services are around there. But in Mytilene specifically, we actually worked with money transfer stations to ensure that, we would actually work with the money transfer stations to let them know when a boat was coming in, so that refugees could safely exchange money under the supervision of IRC, let's say, as well as we're benefiting the local economy by giving that money transfer business access to 60 people as they come in as well. So that's just an example of working with the existing services that are there.
Thank you, Sam. I'll take your question, and then I've got one from Twitter that we'll turn to. Go ahead.
Thank you. So my question is for Alicia. You mentioned earlier that asylum seekers don't have the same institutional support that refugees do. Does that change when they're granted asylum? And then does asylum offer the same access to public services that refugee status does? And then, given your answer, what are the implications of that on women who are seeking asylums access to maternal health care in the United States?
I'll tell you as much as I know as a non-immigration attorney. First of all, the vast majority of the folks who have come in the last 30 years have had very poor success in seeking asylum. The young folks who are coming right now, if they can get access to legal services, are having pretty good success in claiming asylum. But I think the statistics are something like only 10% of the asylum petitions for youth in which there is not a lawyer present are having success. So, because there's no right to legal representation in immigration proceedings. If you are granted asylum, you are given a legitimate work visa, and you have a pathway toward gaining permanent residency. It is a long journey, and the current requirements, for example, for Medicaid, food stamps, and for TANF are that you have to be a legal permanent resident for more than 5 years before you are eligible. So the majority of Central American migrants who are here locally, if they had a pathway toward normalizing their status, it was often through TPS, temporary protected status, which does not actually provide a direct pathway towards legal permanent residency. You can work your way toward legal permanent residency, which I think most people estimate is about a 20-year journey if everything goes perfectly. And then you need to be a legal permanent resident for more than 5 years before you're eligible for Medicaid or food stamps or TANF. For families where children are born in the US, they are US citizens and they're eligible. So you'll have a mixed status family where mom will be undocumented, dad will have TPS, child is a citizen, and another child is in some sort of other conditional status. Each one of them is eligible for something different or ineligible for something different and navigating, but often food stamps for the one citizen child then support some of the nutrition needs for the whole family, for example. Yeah.
Thank you, Alicia. I want to read a question that came in from Twitter. This is from Iru Saliba. Iru, thank you for following us today. The question is, any resistance/challenge to investment in healthcare because the displacement of a population is viewed as a short-term problem?
Can you read that one more time? That's actually from my wife, I should say.
She's a plant.
Yeah, I did not plant it. I don't even.
Well, I'm delighted she's with us. So she's got a great question. Is there any resistance or challenge to investment in healthcare? So I'm assuming the provision of healthcare, because the displacement of a population is viewed as a short-term problem. So I would interpret that as a government maybe being hesitant to jump in and provide healthcare because this population may not be considered one that's going to stick around.
I can actually give a concrete example. I don't know if she had this in mind. But so I think this is where advocacy and collaboration come in. And I think to back up a little bit before I answer the specific question, what was interesting to me for the panel was that I feel like everybody touched on the fact that none of us are doing direct implementation in the purest sense, right? Administering vaccines ourselves, doing primary healthcare ourselves. But at the same time, we did talk about a very clear role for humanitarian agencies within the realm of municipal government services within cities. And I think one concrete example on working with actually the Ministry of Health for the Mafraq Governorate of Jordan, of northern Jordan, we actually entered into a partnership with them where we said that you take care of 70% Jordanians and 30% Syrians, whereas we, the IRC, we will try for our patients to be primarily 70% Syrians and 30% Jordanians. And so through that, there's sort of, it's not enough to just sort of say we're here to help. What you have to do is sort of have I don't want to call it a business agreement, but sort of along those lines where you're sort of saying you have a need, we have an expertise, and what is the relationship from there? So goodwill is great, and just being willing partners is great, but also figuring out from a very practical logistical perspective how you can fill a gap and also strengthen the overall delivery of health services. I think that that's the role that humanitarians are getting better at playing over the past 10 years. There's still room to grow, but also figuring out, again, that example I gave was for the short term. So how do we get better at making initiatives and programs like that sustainable over the long term is a question that I still have.
Fair enough.
I think if you work with refugee populations, you know that there's not a whole lot that's very transitory about needing to care for refugees. They are refugees for many years, decades, on average. And so any building of new services really does need to be planned for the long term. And if there's government hesitancy due to a sense of transitoriness on the part of the refugees, I think that's probably something where, in addition to advocacy, we would educate. I think if there is, in my experience, when there's government hesitancy to build services for refugees, it's because they know they're going to be there for a long time. And governments often would rather they not stick around. They'd rather pass them along or send them back home or something like that. And one of the methods of trying to do that is sometimes to not build the services. So it's kind of an uphill battle either way.
Yeah, interesting. Yes.
Speaking of government hesitancy, my question is to the entire panel, and that is my concerns that the present administration wants to slash practically everything that you're doing. So I wonder what your thoughts are.
Is that the question? I think it's fantastic. I just think it's the best possible scenario. No, I think IRC's donations grew. I don't know if I'm allowed to say this, but they grew exponentially after the Muslim ban and after initiatives like that. And I think we're talking about urban here, so I'm just going to generalize it to the urban experience. I personally, and I'd be curious to get others' opinions, and this is me speaking, I have to be clear, not the IRC. I've personally had much more success engaging with municipal governments than national governments. Just because, and especially when you're talking about urban displacement, they're the ones who are dealing with the problem firsthand. They're the ones whose services are overburdened. They're the ones whose communities are being welcoming of new Ammanians or new Beirutis or new Athenians, right? And so while ministries, of course, have a very important role to play, and national governments are ultimately the decision maker in the long-term policy of refugee status or who gets permanent status where. In the short term, the people who are most active in implementing solutions have been the municipalities, at least within the Middle East and Europe, I would say. And I can speak for the municipality of Amman, who's been very willing to understand how to better incorporate refugees and marginalized. The city of Paris recently asked us to help them with their short-term response, which has been beyond their purview, let's say, but still benefits from the leadership of the mayor of the city. And I think that's, what I would like to see is advocacy from the local level to the national level. And what I often tell municipalities that I work with is figure out what works at a small scale and use that as your evidence to advocate at a large scale. Use that as lessons learned that you can share with other municipalities you for those capital cities that are resource rich and can impart good knowledge on maybe those municipalities that are a bit more effective but don't have the capacity to address them. And so I think that's sort of where the opportunity lies, is on the willingness to act at the local level. And now the question is, how do we translate that to the national?
Does anyone else want to jump in?
Just to say that the experience in Egypt has been the same. the district level offices have been very, very supportive of the program and have done everything on their part to make it work. And I think there are two things. Maybe how we bring about, how we advocate to bring those services or to better those services in the areas is a good thing, by giving them the leadership role, by involving them, not coming in with our own kind of streamlined way of thinking. And I think also making sure that the benefits are clear. So in our case, the benefits of like what we were adding into the health system was pretty clear for the district health offices.
I would say at La Clínica del Pueblo, as a community health center that serves immigrants, Latin American immigrants, and benefited greatly from the Affordable Care Act, it's felt a little dire recently. If we were sitting on top of a coal mine, maybe it would feel a little more like we're in the crosshairs of public debate right now. Along with reproductive health care rights and, the gay community and, name the other hot button issue that we're working on, it's felt challenging. I agree with the other folks on this panel that at the local level, I think, is where we feel like we have power and where we can move agendas. But we recognize at La Clínica, we're funded by HRSA, SAMHSA, and CDC. These are significant funding streams to support our work in disease prevention and health promotion, substance abuse treatment, and beyond. If those budgets are slashed, we're going to have a lot of people with much more grave healthcare needs. Our work right now is in building the case for the economic logic of the preventative care, of the access to care, and the cost savings that comes from providing the right care at the right time at the right place, as opposed to hospital charity care budgets that will be exploded when really sick people have no other alternative but to show up in emergency rooms. I don't know that that has translated to the national debate right now, but we're going to keep raising our voice as much as possible. And really, I think the international guidance, I think, is great guidance here locally as well, of, at the state level, at the county level, at the municipal level, really looking at how they manage their constituents' direct livelihoods and direct needs is scalable and translatable to a national agenda. We have to elevate those solutions as loudly as possible.
Thanks. Okay. Do we have, looks like we have another question in the back and then in the front here. I don't know if do we have a microphone?
I have a question.
You've got a microphone?
Someone else?
That's power. Go for it.
You just had it in your back pocket, right?
Yeah.
I was curious if any of you have done research on attitudes of healthcare providers, because so much of the trust you were talking about to access services requires a belief that the service you'll get will be compassionate and kind and that you'll be welcome there. And if your system's already stressed, let's say the one in Amman, how do you just add these thousands of new patients and expect the service providers to be glad to see you when you come in with your baby?
Yeah, we actually did quite a lot of work right from the start, and one of them was whenever we planned any kind of training that was directly related to reproductive health, whether it was a training on family planning or post-abortion care or a training on newborn care or IMOC, the first day and a half of that training would be focused just on the whole issue of emergency health and refugees and what their needs were. And through those, there would also be exercises within that day and a half where we would look at the providers and try to gauge their attitude and what was bothering them about their service provision. So that those trainings were really very helpful. A lot of things came out of those which were very much related to their work situation. So some of those providers had too much of a workload, or had to see 50 women a day, but as well as fill 2 registers and so many forms. So we were then able to take those that feedback back to the district health office and look at how some of that could be helped and assisted with. And that's how those facilities that this program was piloted with actually developed a digital system of entering data, and then provided data entry staff to the health facilities and had computers at the health. So there were certain changes that happened because of that day and a half where people were allowed to say, or doctors and nurses and midwives were allowed to say what their issues were. But having said that, I think it's important to highlight that there is high staff turnover. So even if we're able to do this with a certain number of nurses and doctors and midwives, the same people might not be at that health facility in another 2 months or 3 months. So keeping that challenge in mind, it's a long walk.
Thank you. We have a question in the back there.
Hi, my name is Naoko Kozuki from the IRC. The examples that were given today were mainly middle income contexts of the urban context. And I was wondering if there are differences or unique challenges when the host country is low income, other than the obvious example that, it's poor. But if you can comment on that.
It's a lot harder.
Right, exactly.
Yeah, I mean, it's an excellent point, because the ability to take in a surge of refugees obviously is vastly different in a high-income, middle-income, or low-income country. I think if you're working in a really poor country, the underlying problems there are such that they're already overwhelmed and already over capacity with a lot of public health services, and then to add refugees is just undoable for a lot of people. So I think in those kinds of contexts, aid agencies often will find themselves trying to create parallel systems in many ways to help the refugees, because there just isn't a lot of excess capacity. The other thing that can be tried is to try to improve the local capacity, which is what we'd always like to do in a sustainable way. But when resources are very, very tight, it's much harder for the local population to be willing to kind of work together and share with the newcomers. So that's always a challenge. But you're absolutely right. It's much harder.
Go ahead.
Thank you very much for your work. My question is, I have two small points. The feminist approach of, in my opinion, the feminist approach of the problem of sexual violence, I believe it exacerbates the problem. Simply put, the solution for this problem is to educate the men about the women, and to educate the women about the men it's never too late for adult education and character building program. So my question in general, especially to Sam, what do you think of adult education as I mean for alleviating urban poverty in general worldwide, whether it's here in the United States or in Egypt or in Sudan, wherever it is. My second question: what do you guys think of, in the Middle East or throughout the third world? We cannot afford American-based health care system, but yes, we could afford American-based health and wellness program. It's very if we give them the science, they will share it, and they will take care of themselves, and they will educate each other about it. Not to mention nutritional needs. There is no doubt that the nutritional need of those people could be met through regional collaboration.
Go ahead.
Yeah, I think, I mean, you brought up a couple of different things. So on eradicating poverty, I don't have that answer. I'm sorry, but I'll answer your other questions. I think, when what? Alleviating, right? Okay. Okay, you touched on two different things. On the issue of urban violence, and again, sorry to speak in general terms, but you spoke about educating men. I think, and women, yeah, and thank you for bringing that up actually, because I think that's there's the victim side of the response, as well as, if you're talking about prevention, it's the perpetrators as well. And I mean, even amongst my colleagues, there's some controversy about how much we should interact with perpetrators of violence. But the only thing that I want to highlight is the importance of context and contextual understanding, so that you understand what the ultimate drivers are and what the points of tension are. And I can give the example of the specific example of Germany, which is undergoing a massive I'll call it integration, although there's sensitivities around that word, of a little bit less than 1 million people. And there's a lot of tensions around the men seeing women working in jobs that are typically reserved for men back in Syria, right? And so there's a whole ongoing process that now needs to happen in Germany for both the German and the Syrian, and as well as any other residents of German cities, to sort of facilitate a dialogue. And even when you have positive moments, you'll just have just as many challenging moments in having that dialogue. But I think persistency of just maintaining it, even when you have bumps in the road, and figuring out what the catch points are, is really it really depends on context, because you'll see there's some instances when you talk about the coming together of two different societies, there's points where refugees will learn the German language, but when it comes time to removing your headscarf or something like that, then that's when you really run into trouble. So there's specific catch points within culture that you also need to then do more education on the host community side. And so I think context matters. I think the topic that you're talking about matters. And that's probably why I can't give you one specific solution as of now, other than to really understand where you are, and understand the dynamics of the community dynamics of multiple different communities and multiple different nationalities at play. So I don't think I answered your question that well, but.
Thank you, Sam. In the interest of time, I'm afraid we're going to need to wrap up. And before I turn the mic over to Roger Mark to sum up, which frankly I couldn't begin to do, so I'm delighted he stuck with that. I want to thank our esteemed panelists for spending time with us today and shedding light on some really key issues as we think about maternal newborn health in urban humanitarian settings, and the issues that impact not only them, but impact their families and the ecosystems in which they find themselves. I also want to say, on behalf of the Maternal Health Task Force at the Harvard T.H. Chan School of Public Health, how delighted I am to be part of this great collaboration with Save the Children and the Wilson Center. It's been wonderful, and it's truly been a privilege to get to be with all of you today. So thank you.
Thank you very much, Mary Nell. Wow, talk about real talk. I did have my checklist as we were going through the conversation, and we seem to have covered so much of it. I think we started our discussion today by just contextualizing, looking at the scope. We talked about the breadth of the refugee crisis. We talked about urbanizing trends, and then we focused on refugees in urban areas. And what really struck me was the specificity of looking at these issues in an urban setting. And, Sam, I was quite struck by your comment. We're looking at a city in crisis, but also crises in a city. So that was, I think, very important framing for us. We talked about maybe looking at refugee communities who at times, and this was a little new for me, who may be removed from the label of a refugee in a city context, but yet there were two strikes against them, this refugee experience and the marginalized experience, and what that meant in terms of legal and social discrimination. I think an important component of that came out of the discussion was defining the right to the city. And I found this very interesting, looking at it from a point of displacement, but those who choose to come to the city and what their expectations are in making that deliberate choice to come to the city. So how do we navigate that? And what are the parameters that we see happening as a result? And I think one of our panelists described it as it's complicated. Right? It is complicated. We looked at health service delivery and access to health services. We look at people who are forced to move quickly and had not taken materials with them. So they find themselves and they don't even have what they need to live. We talked about the importance, and this kept coming up, the importance of networks. And we talked about support systems, being isolated from those systems, but also looking at informal network and the importance of informal networks and to the degree to which there was some mistrust of the formal network. So an important component in navigating that complexity. Very interesting, and I really liked, Alicia, that we had a domestic case. You know, very often in our conversations, we're only looking internationally. So I really appreciated that contribution in our discussion today and the points that you raised with regard to looking at how it's changing age, changing family structures, and this sense of a transnational community or family. And I think to really epitomize this complexity that you talked about, I think the example that you gave of the varying mixed legal status of different members of one family. It's like, wow, how do you even begin to figure out how you manage that? So I think you really brought that complexity home for us. And I think we talked about a number of challenges. And as I think of the challenges, I think the comment that comes back to me, it's like you're giving birth again. You know, this is not easy. This is not an easy situation. From language problems to looking at stunting and chronic problems around chronic malnutrition, to lack of skilled birth attendants, to needing to use transportation to get to these services, even if you use your card, a lack of understanding of the status of refugees, and yet women will continue to be pregnant. Ultimately, we have to confront these issues. Very interesting also to see different patterns of refugee flows in urban areas, and having the example of the issue of unaccompanied minors and how we deal and manage with that right now. Of course, looking at the different traumas the different family members go through and what happens when they come together again. And of course, the number of instances that we spoke about with sexual violence. And I'm really glad that we didn't leave it there. We really looked at what we can do, what's happening, what's the future direction. I think we talked about this in the context of public service. Why was it important to look at public service? We mentioned various times the opportunities for collaboration, for system strengthening, for organizational development, for advocacy, and really focusing on local systems that already exist in the city and the importance of strengthening those systems. I kept hearing that once again as a very important message coming out of the discussion today. The role of technology, how that is helping us to bridge some of these issues. And I think with your participation, that even came up in the question of cash transfers. How is that different now? Are we sure that we're not increasing the vulnerability of these beneficiaries that we are working with? So what does that mean? And how do we monitor our progress? What do we do with that information? I particularly like the fact that Sam's wife sent us a tweet holding him accountable. He had to answer the question. You know, it was a good question that he didn't plant. But, you know, you have these short-term responses. How do you get to long-term financing for these issues? I think really, but there's an opportunity there to think about how we bridge that gap. I really appreciated Sam's point about refugee.info, you know, providing technology to provide information to refugees for them to make informed decisions that help them to reduce their individual vulnerability as they have to move. Very interesting, a number of community-based models, community centers that were serving, providing a variety of services, but were also serving as a hub for specialized care and thinking about how that linked to other programs overall. And I think finally, just to say, the final point I think I heard us discussing was the ability to take action, a very positive action at the local level, but how do we scale that up and take that up to the national level? Wow. Real talk. Thank you, guys. This was an amazing conversation. Once again, it has been recorded. It will be video archived on our website, on our blog platform, New Security Beat. We will write a summary of today's discussion. So please go back and have a look at that. And we will invite you to keep tuned for our third dialogue in the series with Save the Children. So please join me in thanking our panelists for an excellent discussion today.